Hello, my name is Dr. Sneha Kohli Mathur, and I will be talking to you today about neurodiversity, this concept of neurodiversity, and how you can use it to better the services that your child receives. So I'm going to share a PowerPoint with you. I am in professor mode right now, so I'll be sharing this PowerPoint to help me explain to you what neurodiversity is. So the DSM is what psychologists and doctors use to diagnose different disorders such as autism spectrum disorder. But there's a complaint, especially amongst the autistic community, that the DSM fails to represent or even understand the lived experiences of autistic individuals. So what I'm going to talk to you today about is neurodiversity and also something called the Monotropism Theory, to present an alternative way of understanding autism and what implications that has in society to both us as parents as well as us as concerned members of society, just trying to create a more inclusive world for our children. So I like this quote, which was written by an autistic person. Autism isn't something a person has or a shell that a person is trapped inside. There's no normal child hidden behind the autism. Autism is a way of being. It is pervasive. It colors every experience, every sensation, perception, thought, emotion, and encounter. Every aspect of existence. It is not possible to separate the autism from the person. And if it were possible, the person you'd have left would not be the same person you started with. This image basically depicts the social model of disability, which is neurodiversity in relation to autism, and the medical model of disability. So oftentimes doctors and psychologists, medical professionals are trained in the medical model of disability, which understands autism or any disorder or any limitation as an impairment, something that must be cured or fixed. Whereas the social model of disability understands a disability or disorder as something that should be understood. And what societal supports can we create to better support someone who has a difference? So in this image, there's an individual in the wheelchair confronted with stairs. How does the person go up the stairs? The medical model of disability says that they need to learn how to walk in order to go up the stairs. The social model of disability says there should be a ramp in every building so anyone can access the building and the supports that come in that building. How does this relate to autism? So right now we live in a very ableist world. Ableism is the discrimination of and oppression of disabled people, and this societal belief that being able-bodied and able-minded is normal and preferred. Whereas the social model of disability reconceptualizes autism or neurodivergence as something simply to be understood, a difference to be understood. So on the left side of this chart here, you'll see the deficit model, the medical model of the DSM talks about autism criteria. And on the right-hand side, I created just an alternative way of understanding and thinking about autism through the social model of disability or neurodiversity. So instead of thinking of autism as a persistent deficit in social communication and social interaction, we can reconceptualize how we think about this as simply a diversity of human minds with an infinite variation in neurocognitive functioning within our species. Deficits, number two, deficits in social emotional reciprocity can be reconceptualized as neurodiversity is simply a natural and valuable form of human diversity. Deficits in nonverbal communication can be thought of as the idea that there is one sense of normal or healthy brain or mind, or one right type of neurocognitive functioning, is simply a culturally constructed fiction. There's no one normal or right way of being. We're all different and we're all equal, and we all deserve to be here and loved and respected. Finally, deficits in developing, maintaining, and understanding relationships can be understood as social dynamics that manifest in regard to neurodiversity are similar to social dynamics that manifest in regard to other forms of human diversity, like ethnicity, gender, or culture. These dynamics include dynamics of social power inequalities and also dynamics by which diversity, when embraced, acts as a source of creative potential. So the neurodiversity paradigm was created actually by autistic people, and it recognizes autism as a form of divergence rather than a deficit. What they're saying basically is that many challenges that people with autism face can be alleviated by environmental changes rather than focusing on neurological differences as a deficit. So in treatment, this means that focusing on someone's strengths and how you can use those strengths long-term in life would be a better mode of treatment than focusing on the deficits, trying to fit into societal conceptions of normal social behaviors. And following that is the Monotropism Theory, which was also created by neurodiverse authors. So neurotypical meaning not having a diagnosis such as autism or ADHD or some other form of neurodivergence. And this criteria, this theory was actually created in direct response to the DSM criteria of autism spectrum disorder, because autistic folks were not happy with how autism was being portrayed. There's no understanding in the DSM criteria of what autism looks like or feels like, and that's where monotropism theory comes in. Monotropism highlights that there are different cognitive processes that people use to focus their attention. Some people are able to distribute their attention across many different interests, but monotropic people, which oftentimes is autistic people, tend to focus and concentrate their attention on a few interests at a time, specifically items that are of special value to them or that they find interesting. So in a nutshell, autistic people can typically pay attention to a few topics of interest to them, but they may have trouble tending to tasks that are not valuable to them, specifically because their attention resources are focused on other tasks with personal value. That makes sense, right? So viewing this as a strength, someone with autism can focus really, really well on a task if it's valuable to them. And so how can we use that in our teaching and in our therapy? So restricted repetitive patterns of behavior, interests, or activities, instead of thinking of this as a restriction, think of it as a social model, monotropism theory, as simply a different cognitive process that people use to focus their attention on different things. The stereotyped repetitive motor movements and use of objects or speech can be thought of as just different strategies employed in the distribution of attention. This insistence on sameness or inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior can be reconceptualized as those who are monotropic may have trouble attending to a task that is not perceived as valuable to them, specifically because their attention resources are focused on other tasks that do hold personal value. Highly restricted, fixated interests that are abnormal in their intensity or focus. Because of the narrow attention tunnel, unrelated information might simply not be processed. Highly restricted, fixated interests that are abnormal in intensity or focus. Again, this word abnormal, it connotates something negative. But instead, let's reconceptualize this as because of the narrow attention tunnel, unrelated information might not even be processed. Hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. Instead, think of this as neurotypical language does not even speak about experiences in terms of sensory experiences, but rather what these experiences meant or what inferences were drawn from the collection of sensory experiences. This difference in language use makes it difficult for an autistic person who primarily experiences the sensory input without the attached social inferences to explain their own experiences. So these are two somewhat complex theoretical frameworks to understand autism in a different way. And just to be clear, this is not to say that people with autism don't have a specific set of challenges or struggles that they have to deal with in the world. This is to say, let's understand those struggles and the responses to those struggles differently. Let's see what we as society can do better to support someone with autism rather than presuming that the differences are deficits. So how do you use this information as a parent? One of the biggest questions I get asked by parents is, what do I look for in a good interventionist and a good therapist? Well, first off, you want to look for a person-centered approach. So the care is personalized. The care is not just the therapy or the intervention is not just a cookie cutter approach, but rather the person, your child, and yourselves are involved in deciding what kinds of therapies and what kind of interventions are used, what kind of techniques are used. It's personalized to your needs, to your culture, to your child. The care is coordinated. So look for someone who is coordinating care across different therapists, not just I'm providing this intervention and this intervention will fix all your problems. No, it's oftentimes care should be across many different medical professionals so that all of your child's needs are met. And maybe most importantly, the care is enabling. The care is empowering to your child and to yourselves. And of course, you should always be treated with dignity, compassion, and respect. And if you are not, then that's a sign that your interventionist is not a good one. Here are some questions to ask your interventionist about. What are the goals of the intervention, both stated and unstated? Who is involved in coming up with and writing these goals? Are you included? Using these concepts of neurodiversity and monotropism, you should be included. Your child's strengths should be highlighted throughout the course of treatment. Number 2, what beliefs about autism are implied by the intervention? Why does it target a specific skill or behavior? Is it because the interventionist told you that that skill or behavior was important? Or is it because it's an important skill to you to learn, or for your family to learn, or for your child to learn? Number 3, who benefits most from the intervention? Does your child benefit most from the intervention, or does society benefit most, or does the student's teacher benefit most? Who is benefiting most? The answer should be your child. And second, your family. Number 4, would you consider the intervention ethical if it was performed on a non-autistic person? So we get this a lot with stimming, for example, hand flapping. If the intervention is to completely stop hand flapping with someone who doesn't have autism, if I sat here and flapped my hand in my office while I was doing work, would I be needing services to stop hand flapping? Probably not. If it was to a point where it was not allowing me to do my work, we might talk about an intervention where you engage in the behavior for a certain amount of time or in a certain place so that you get that deregulation and can still get your work done. But the flapping itself would not need to be eliminated completely just because it might look weird or different or atypical to the rest of society. Number 5, what are the possible or known long-term effects of the intervention on the person? And what are the possible or known long-term effects of not having the intervention on the person? So weighing the pros and cons, both short-term and long-term. The answers to these questions will reveal more about the intervention in question, and will hopefully help you focus on your child and getting their needs met. Evidence-based treatment. So always look for professional organizations that have standards for levels of evidence. You want to look for evidence-based treatments because they have the most chance of success with your child. So oftentimes, if there's a website that says this intervention will cure your child, I see that as a red flag, because we're not looking for autism to be cured. We're looking for it to be understood and accepted, and along the way, helping to support autistic individuals getting the supports that they need. Autism is a lifelong condition, and learning these various supports should be the focus of therapy, not trying to come up with a cure. These are some examples of evidence-based interventions for people with autism spectrum disorder. And again, another guide for parents, questions to ask yourself when you're deciding, is this an evidence-based treatment, or is this perhaps something that looks appealing but will not actually gain results for my child? One, how did I hear about this treatment? So seeking out original research that has been published about the treatment, or differentiating between media sources that reference original research and those that do not, and verifying information obtained from informal sources with professional sources are strategies that you can use. Two, is the treatment supported by research? And three, what do I want out of this research? Self-reflection here is key. Do I want my child to fit in more? Is that why I'm pushing for this treatment? Or do I want my child to just be more comfortable in who they are and getting the supports they need to make sure that they are successful in their endeavors that they choose? And then these are just more in detail questions that you can ask yourself. This is something that parents come to me a lot with, is how do I know a treatment is legitimate? And these are some tools you can use to consider. Okay, so in my personal research, I have spent the last several years speaking to autistic individuals and reading autobiographies written by autistic people. And so with this knowledge and these conversations, I've created guidelines for different people in how to use neurodiversity, these concepts of neurodiversity in our practices. So if you are engaging in some sort of research, there are many research projects going on to better understand autism and the needs for autistic individuals. Always make sure that whenever possible, the researcher is collaborating with you, collaborating with your child. And qualitative data just means, are they trying to get to know your story, or are they just going down a check mark, a list, and checking boxes? Checking boxes doesn't get to know you. It puts you in a cookie cutter kind of, it lumps you up with everyone else. Is a focus on understanding your child's behaviors or just labeling the behaviors? Do you feel that your child's voice is central in the research? And are they going to distribute this research in ways that you and other parents can actually access it? Or is it just going to be circulated within academia? These are all things to ask, and sometimes you can even ask the researcher to consider posting some of their material in a way that's accessible to you as parents, because as you as parents and your children as autistic individuals are the biggest stakeholders in our research and in our services. It is designed for you. We are trying to understand what is best for you, so you should have access to the research that we are doing. Things that you can pass along to your children's teachers, therapists, and psychologists. One, a special interest, or what is referred to as a fixation or obsession in medical terms, can actually be used to everyone's advantage. By using the autistic person's special interest, teachers and practitioners can engage the student in a meaningful way. Special interests can also be used as rewards to motivate students to engage in an activity. Conversely, special interests should not be taken away as a punishment, because doing so will lower motivation to succeed. Number two, whenever possible, include the student in treatment planning. So that means in IEPs, try to include your child in IEP meetings so they know what's going on with their support services and they can give input in things that maybe are not being addressed. Number three, autism is more than the diagnostic criteria listed in the DSM. To truly understand their needs, listen to the diverse experiences of each autistic client or student. So make sure that your teachers and therapists are, again, not just putting them in with this cookie cutter approach, but actually getting to know them and supporting their specific needs. And finally, do not impose neurotypical expectations and activities on neurodiverse individuals. Everyone has their own set of strengths and challenges, and it is imperative to get to know your neurodiverse clients and students and work on the needs that they desire. not which are imposed on them. For parents and family members, whenever possible, talk with your child rather than about your child. Include your autistic child as much as you can in treatment planning. Let them share their concerns and experiences with doctors, therapists, and teachers and other medical professionals or their care team. Share your child's autism diagnosis with them at the earliest appropriate time. Many people I've spoken to revealed that their diagnosis actually helped them understand themselves better. They knew that they were different than their peers, but they didn't know how or why. So having an understanding of where this difference came from helped them understand why they experience the world differently. And finally, discuss your child's specific strengths and challenges related to autism and how you can support them. Ask them if and how they feel different from their peers and how you can support them. To society in general, someone might ask you, what can I do to support you and your family? And these are general guidelines that you can share with them. If you are confused by somebody's behavior, assume that they are just as confused by your behavior. It is not the neurodiverse person's responsibility to conform to neurotypical social norms. There is a mutual lack of understanding between neurotypical and neurodiverse behaviors, and both of us must strive to understand each other. It's not solely the responsibility of your child or the autistic person to change themselves to fit into society. We as society must also create a more inclusive and understanding and accepting community. Number 3, understanding an autistic person's special interest is a great way to engage with an autistic person. Remember, just because they might be speaking a lot about one topic does not mean that they are not interested in you or your topics of interest. Rather, their monotropic attention tunnel allows them the capacity to focus on one emotionally charged topic at a time. And finally, assume that the stereotypes you have about autism are simply not accurate. I hope this was helpful for you, and I wish you the best of luck.